Good evening. I'm Drew McClean. I'm a consultant radiologist down in Southampton. Tonight we're going to talk all about aneurysms. So at Southampton we treat a wide range of aneurysms, ranging from really quite large aortic aneurysms down to very small bleeding visceral pseudoaneurysms. Actually, all the aneurysms we treat are really important. And then when I was putting this talk together, I actually thought that treating aneurysms is one of my favourite parts of the job, actually. And I think that really comes down to why we treat aneurysms, because if you don't already know, there are two main reasons why we treat aneurysms. It's quite simple. Number one, the aneurysm is already ruptured and we want to stop that patient from bleeding to death, essentially. Pretty good reason to treat an aneurysm. And number two, we think that aneurysm is at risk of rupture and we want to treat it before it ruptures. There is one main exception to that, which I'll cover quite early on, but those are the two reasons. So if you think about that, you can see why it's really quite rewarding to be involved in aneurysm treatment as a consultant, because you make a huge impact on the lives of these patients. And I think the reason I was so keen personally to do this presentation, the why I wanted to do this, was because I see a lot of juniors and a lot of medical students having the same misconceptions that I did at that stage. And I just thought by maybe covering some of them, I could stop you making the same mistakes I did when I was a junior. Two reasons I think you should definitely consider being not just a consultant interventional radiologist, but including aneurysms as one of the areas of treatment that you offer. Number one, you need the full skill package if you're going to treat aneurysms. You need to be an expert at closure devices. You need to be able to track large sheaths around tortuous friable vessels. You need to be able to deploy stent grafts with millimeter accuracy. And you need fine motor skills for microcatheter manipulation for embolization of small bleeding pseudoaneurysms or endoleak embolization. The other really good reason I enjoy treating aneurysms is this constant new technology. I'm sure you'll know this. Interventional radiology is on the forefront of new medical devices and technology, but particularly with aneurysms, there's a lot of new devices and new technologies. And implementing these safely and effectively for patients can actually be a really big challenge. It's also really nice interacting with industry. They're a group of people that have quite a different background to us sometimes as doctors, and it can be quite refreshing working with a different group of people. The third reason I didn't put on here that I just thought of more recent is we work really closely with vascular surgeons. At Southampton, we have a great bunch of vascular surgeons, and it's an absolute pleasure working with them. Again, they're a group of people that have a different training background to us, and working alongside them is one of the favourite parts of my job. So how I'm going to do this tonight is, firstly, we're going to talk all about aortas. You can't really talk about aneurysms and not cover aortas on an interventional radiology talk. And we've already covered why, really, actually, got that out of the way. I'm going to talk about when we treat them, how we treat them. And I also just want to cover the controversy about aortic aneurysms and endovascular treatment, because you may well have heard a bit about this. And even me as a consultant, I find some of it a bit confusing. So I'm just going to try and put it in understandable terms. And then if we do have time, I'd love to cover other aneurysms, in particularly pseudoaneurysms, because they're one of my favorite things to treat. And how we do that, is a really interesting technical point of interventional radiology that when you start interventional radiology training, you'll learn more about. And that's one thing I really want you to start doing, is start imagining yourself as a consultant interventional radiologist, because believe me, it's really not that far away. So why do we treat aneurysms? Like I said, the main reason is rupture, but there is one exception to this, okay? And it's really important to know about. And so imagine you've got an aneurysm in a blood vessel like this. Obviously, you have turbulent blood flow within the aneurysm, and that can basically build up. So you get thrombus formation within that. And then one of two things can happen. Either bits of that acute thrombus can break off and go and lodge in the smaller vessels. So distal embolization is one complication. Or the other one is the aneurysm can just completely thrombose. And both of these can cause acute limb ischemia without being, which is a really serious complication, is not related to rupture. I mean, you may already know this, but this is why we treat popliteal aneurysms, actually. And I think it's a really important exception to mention, because because you'll come across it quite a lot. So let's go back to aortas, and we divide them really for treatment into thoracic and abdominal. And to try and make this maybe more relatable or understandable, I'm going to tell you about a real case that came through our MDT recently, and how we decided on what the best treatment was for them and how this guy was treated. So this is a 69-year-old taxi driver, and his aneurysm was picked up by screening, which is how we pick up a lot of aneurysms now. So above 65, men are invited to have screening of aortic aneurysms. Past medical history, he'd had a previous MI and some stents, and he was type 2 diabetic. So, what do we do with this guy? Realistically, do we repair his aneurysm? Do we leave it? Do we surveil it? Do we tell him not to worry about it? And really, if you think about it, there's a huge number of factors that plays into this decision. And essentially what we're doing for him is we're trying to balance the risk of rupture versus the risk of putting him through an aortic repair. And the one statistic that is really worth bearing in mind is if his aortic aneurysm ruptures, this guy's got an 80% mortality rate, out of hospital. So that's not good odds, really, is it? So if this was 25, 30 years ago, this guy would have had two options. Either we do nothing for him, or he has an open aneurysm repair. And to try and put this in simple terms, obviously there's the upfront risk of the repair itself, and then there's a long-term risk, the risk of rupture or risk of other mortality causes. Now, obviously, if you do nothing for him, there's no additional risk to him, and it's quite low. Whereas open surgical operation has got a significant risk to life, also risk of major events such as stroke, PE, DVT, heart attack. But then over time, and the reason we obviously put patients through that is over time that initial upfront risk really pays off because they have a much lower risk of rupture. But what EVAR did when it was first developed, it developed this third option. So it's an endovascular aneurysm repair. We can do it. It's a minimally invasive procedure. And the idea was, let me show you this video just of how we do it. If you've never seen an EVAR before, this will run through it in about 10 seconds. So basically we get percutaneous access to the groins, we put a sheath up and put the stent graft through the sheath, and we uncover it so it self-expands. The key thing is you want to seal it below the neck there, as you can see those arrows. And obviously don't cover the renal arteries. You can see why people call these the trouser grafts, because it splits from one main channel into two channels. You then get access up this second channel, up this other limb, and you put a stent into that. You can see the arrows at the top just indicating that you get some suprarenal fixation, so like a crown springs open and holds the stent graft in place. And that's it really. In principle, it's really quite simple and quite nice. Obviously, as anatomy gets a bit more challenging, tortuous, shorter necks, things can get really difficult actually. They're not all that straightforward, and mine certainly don't take that long, they take a bit longer. So EVAR was seen really as this great thing because, hold on, we've got this low upfront risk, but also this lower long-term risk. But the long-term risk of rupture and of other complications just is not as low as open surgery, and I don't think anybody would claim it is. But this area here is where all the controversy comes from, basically, and deciding what's best for patients and how much of the initial risk is worth taking up front. So let's just go back to our patient and ask, so when should we repair his aneurysm? And really, for him and any other patient, you should repair the aneurysm when the risk of rupture starts to outweigh that upfront risk to them, that you're going to put them through with an operation or procedure. And to try and give you an idea of numbers for that. So this is the graph that's really important. And basically, along this side, you can see the chance of rupture. And on the bottom, you can see as the aneurysm size increases, so does the chance of rupture. So for less than 4 or 4 to 5 centimeters, you have very low risk of rupture, less than 10%. And then around 5 to 6 centimeters, that's when it starts to approach an area where, you might be a bit uncomfortable as somebody with an aneurysm. It's to about a 10% chance of rupture. And then up to, above 8 centimeters, you've got 50-50 yearly chance of rupture. I personally wouldn't be too thrilled with those odds. So the first thing I want to mention about this graph is that it's only done on size. And actually, if you think about an aneurysm and how many different factors will contribute to that risk of rupture. But size is one of them. So things like blood pressure, thickness of the wall, thickness of thrombus, location of the aneurysm, the morphology of it. To take just one of these and go on size is really is not taking the full picture into account. On the other hand, it's really simple. And if you're trying to make decisions about which ones we treat, it's really quite helpful. So what we actually do, this is what everybody does in the UK, is we draw a line, bang, slap down the middle of this group, 5 to 6 centimeters aneurysm. And we say when you get to 5.5 centimeters, we consider repairing your aneurysm. Okay, so below that we wouldn't consider that. Above we would. Doesn't mean you definitely get an aneurysm repair. Obviously there are a lot of other factors, but it means at least we might consider it. Okay. And that's a key learning point. It's just, if you're going to remember one number tonight, I'd remember 5.5 centimeters, because that's the threshold for elective repair, basically. But the problem with doing that is if you see below the line, there's patients down here, the actual, people who have an aneurysm that has ruptured, okay, and we haven't offered them a repair, which just goes to show that the size threshold doesn't catch everybody. The two exceptions to that, which is another key learning point that you should always remember, is exceptions to that rule is if their aneurysm is symptomatic, so if they have abdominal pain, basically, or if the aneurysm is growing quickly, so more than a centimetre a year, then we still repair it in that group. So they're higher risk patients within that group. The other negative of this strategy that we have is that you can see there's a big gap here where patients who have an aneurysm that we offer repair to, but their aneurysm will never rupture. They'll die of something else. That's also not a great thing, is it? So, whenever you have something that's maybe more complex than we can easily appreciate, it's always a situation I start thinking, is there some kind of algorithm or artificial intelligence that we should be using? And there are a lot of papers on this, actually, but I just don't think it's gained enough evidence or momentum or traction to really be, because you think it has to be something that's easily usable for everybody in the UK to use. There are papers out there that use computational flow dynamics within the aneurysms and a lot more accurate working out which aneurysms are going to rupture, but it's just not easily transferable across the whole of the UK. The one thing I was really keen that I wanted to share with you all tonight is something I think is really cool, and it's where we do use an algorithm. And it's not radiologists or intervention radiologists or surgeons that come up with it. It's anaesthetists. And it's to do with the risk of the long-term risk for these patients, but also the upfront risk of the repair. And it's all to do with the cardiopulmonary exercise test, okay, the CPAT. So most patients who have an aneurysm considered repair will have these. They certainly do at Southampton. And basically they get put on an exercise bike, just like here, and they get attached to loads of leads. And it's essentially a VO2 max test. And these old guys sometimes get pushed to their limit, basically, on the bike. It gets harder and harder to pedal, and they have to keep going. And then we get the numbers that we get out of that gets fed into something called the Carlisle Risk Predictor, and it was done by an anaesthetist, John Carlisle. One of the things I love about this is that he just made it accessible for everybody to use. So basically, when he published this, he put a link to the Dropbox, which anybody can go. This is how I accessed it. I found the paper, I clicked on the link, and you have access to all his algorithm and his data. And it's really nice because it gives you this graph which is perfect to show patients. These are the inputs. Okay, I don't know how well you can see that, but it's just basic characteristics of the patient. And down the bottom there, you can see it's got our aneurysm diameter. Then it's got also how they did on the test. And then it's got some of their comorbidities, heart failure, peripheral arterial disease, renal function, things like that. And basically what this gives us is what their risk is, estimated risk of mortality and morbidity for the operation, for open or endovascular, which is really nice to be able to show patients that. But then the best thing it gives us is this, which is the graph of survival probability for that patient, which is such a good visual aid. And you can see the black line is if we did nothing for that patient. They wouldn't even reach 6 years before they had a 50% chance, their 50% chance of reaching 5.5 years, basically, which isn't great because of aneurysm rupture, essentially. The red dotted line is EVAR, if they have an endovascular repair, and the continuous red line is open surgical repair. So I just want to highlight the start of the graph here. because you can see, obviously, on day 0, if you have nothing, you've got the best chance of survival because you're not coming into hospital, you're not having a procedure. And just below that is EVAR, because it's safe, but it's not, nothing is completely safe. And then below that, you've got this solid red line, which is what happens if you have open repair. So you take that initial hit to your survival probability. But you can see it's not too long before those two lines cross, the EVAR and the open repair line. And it's about 3 years before open starts to be a better option for you in terms of long term. There's also something called the P-POSSUM, which is another risk predictor that we can do to give patients an idea of their morbidity if they were to have open or EVAR, basically. And of course, the other thing that our patient needs is he needs a CT scan. We need to plan exactly what the options are for him. Is an endovascular repair possible, or does it have to be open? And then, just to give you a flavour of exactly how we make these decisions, basically these patients will discuss at the MDT, and we have the CT scan, we have the anaesthetist with the CPAT, and we have the surgeon who knows the patient. And how it normally works is I will run through the CT scan and describe the anatomy and what might be possible, EVAR and open-wise. And then the anaesthetist basically comes in with the CPAT and says, look, these are his chances if he has open, if he has EVAR. And then the surgeon normally says, well, this is what the patient was thinking in clinic. And eventually we agree on basically what we would offer the patient, what options we think we could put to the patient we think are acceptable risks. And then the patient, of course, makes the final decision. It's all about shared decision making. So let me just show you this patient scan, okay? Hopefully this is going to play. It's just loading, okay. And what I'll do is, just to give you a flavour of how this actually happens in the MDT, I'll try and talk through it as if I was presenting it. Okay. So what I would do is I'd have either measured it before or just read the report of what it said. So say 5.8 centimetre infrarenal aortic aneurysm, and I always say how many renal arteries we've got. So we've got single renal arteries bilaterally, you can see coming off. I'd say the iliac arteries are normal caliber, not aneurysmal, patent internal iliac arteries, and then you also check the access vessels, so the femoral vessels. I'd say patent and not significantly calcified femoral vessels, because the bit you're looking at, although one of the sides is quite calcified posteriorly, where you're going is through the anterior part of the vessel. So for closed devices, sometimes they just don't work as well if they're anterior. And then we talk about the CPET and we talk about the patient. And then we decide of those 3 options what we're going to offer him. So as I said before, this guy's a taxi driver. That's still his livelihood. He enjoys driving his taxi. He wanted to get back to doing that as soon as possible. And so he was really keen on an EVAR. We decided it was a reasonable thing to offer him, and we went up with that. Obviously, doing nothing for him is not an option, because you can't drive a car with an aneurysm at risk of rupturing. So then what happens to him is he comes in a few weeks later to our day of surgery unit, where he's put in a gown, he's got a cannula put in, he's seen again by a surgeon and an anaesthetist, and he comes through to a hybrid theatre, which, if you haven't seen one, looks like this. So it's a big room, it's got full surgical operational capacity, but also it's got this giant X-ray machine, which is controlled by, as you can see, one of these arms. These are the same arms that they build cars with in factories. So this could easily crush you. So you need a good radiographer who you're on the right side of, who isn't going to crush you with the C-arm, basically. But they're brilliant. They're great rooms, and they're really important for aneurysm repair. So he had his procedure, and he goes to recovery afterwards. Normally he'll go to the vascular ward overnight and home the next day, which is why EVAR is such a good option. Patients are then followed up generally with some kind of scan in about 4 to 6 weeks, something like that. And hopefully this is playing for you. Here we go. So this is follow-up scan. So now you can see the EVAR diverting the flow through the aneurysm. It's not filling the sac. It's not going to rupture. The key things we look for are just that the sac size is stable, that it's not increasing, and that there's no endo leak. Endo leak is not a concern if the sac size isn't increasing more than about 5 millimeters in a year. Is something worthwhile saying. So it's great, easy, but obviously they're not all that straightforward. We do have challenging cases where often the aneurysm is at high risk of rupturing. Maybe it's a large aneurysm. Doing nothing is not an option. Open surgery isn't an option. probably due to patient comorbidities, or maybe they've had extensive previous abdominal surgery, and standard EVAR isn't an option. So for these patients, there's something called complex EVAR, which is just worthwhile knowing about. And the most common indication for complex EVAR over standard EVAR is because the neck length, you need about 15 millimeters of neck, which is just a learning point. But obviously, there are a lot of other factors like angulation or whether it's conical or stuff like that. But it's the neck that's usually the problem. And in those cases, as you can see the image there, we can't just put in a standard EVAR. What we have to do is either put in something like some of the ways of repairing it, like you may have heard of a fenestrated graft, which is a custom-built device with holes for the visceral artery, so you can extend the seal and safely exclude the aneurysm. Okay, I don't want to spend too long talking about the controversy, but it's something I really thought was important to mention if we're talking about aneurysms, because you may have heard a bit about the whole controversy behind EVAR and aneurysm repairs and the NICE guidelines. I actually found it quite difficult to decide what I was going to say about this, because there are two quite different viewpoints, and I can completely see where both are coming from, basically. And so I'm going to try and be as impartial as possible. And really, it comes down to our graph here. Okay, it comes down to the two lines, the EVAR and the open. And you can clearly see that, after a certain period of time, that open gives you the better chance of survival. I suppose the question is, with more modern devices, better seal, and more durable results, are these lines closer? And therefore, are patients probably getting better initial survival probability with EVAR and maybe slightly more of a negligible long-term result? So just before the pandemic, 2019, basically NICE said, look, we haven't written the guidelines for aortic aneurysm, infrarenal aortic aneurysm repair for a while. There's been a few new studies, maybe we should redo them. And so they got together this expert committee of vascular surgeons, interventional radiologists, and loads of other people. And they said, right, here's the evidence. You're going to write some guidelines on it. And so how it works is they obviously draft the guidelines, get sent out to loads of people, and they say, whether they think it's good, whether they're happy. It's basically stakeholder engagement is what it's called. And they come back with comments, and sometimes they get incorporated into the guidelines, sometimes they don't. Basically, these draft guidelines were really controversial because they said, don't do EVAR, and you think about how EVAR is very common practice. And basically it said, look, if you could fit enough to have an open repair, you should have an open repair. If you're not fit enough to have an open repair, then EVAR doesn't offer you good enough benefit, and you'll probably die of something else. They said EVAR may be in an emergency because there is evidence that if you have a ruptured aneurysm and you're an older person, that EVAR is the right thing for you. Okay, but if in the elective setting, it said don't do EVAR. And so when they then went to the stakeholder engagement, there was a big backlash. There was a lot of controversy. I mean, I'm not saying it's all because of that, but you can imagine there are multi-million and billion-dollar and pound companies that produce these stent grafts, and there's a lot of money involved in this. But also, a lot of people really believe that EVAR is the better option. The issue that everybody raised is that evidence that says that EVAR is not as good as open, and the evidence that says that EVAR is not as good as just not doing it if you're not fit enough for an open, is based on trials from like the 2000s, and they said, look, these grafts have improved massively, and so the survival must be better. The problem is, I don't think we've really repeated the same level of studies, but equally, EVAR has kind of become a standard of practice, and it's quite difficult to do high-level studies when something has become standard of practice. So, I mean, what happened was pretty controversial. Basically, NICE kind of just, I think, stopped involving the committee that had written the draft guidelines. They were looking for some kind of big cover story to take the heat, essentially. And of course, then the pandemic came along, which was perfect. So the pandemic hit, and then NICE released these guidelines that basically say, you can do open if you want, and you can do EVAR if you don't want to do open, without really involving the committee. So there was, it was a pretty controversial thing to do. But so EVAR is still there, and people people very much still do it, and personally, I think it's a really good option for a lot of patients. So take from that what you will. It was a pretty juicy situation, I'll be honest. Okay, so the next, I'm kind of running on a bit more than I thought. So I'm gonna do one more case, okay, which demonstrates thoracic aneurysm repair. And this lady basically presented to our A&E a few weeks ago. 75-year-old. She had a collapse with chest pain, and in A&E they noticed that she had a palpable aortic aneurysm. So they're wheeling her around to CT. The whole crash team are there with her, and she has a near arrest in the CT scanner. So the vascular surgeon is there as well, and he says, look, she's clearly got an aortic aneurysm. Let's not bother going through with the CT when she's about to die. Let's take her straight to theatres and repair her aneurysm. So she's taken straight up to theatre, and they open her abdomen and they find an aneurysm there, but it hasn't ruptured. I mean, can you imagine the surprise? So she's stabilised at this point. So they thought, right, well, it's got to be something else. Let's take her back to CT and see what's going on. So she had a CT scan, and this is it. Hopefully you can see that okay. And what you can see is pretty clearly there. Okay, I'll just come back up. It's not only does she have an abdominal aneurysm, she's got this thoracic aortic aneurysm. And this half of her chest is full of blood. So that's the aneurysm that's ruptured. You can see a lot of gas, a lot of free gas from the laparotomy she's had there. So she's had a ruptured thoracic aneurysm instead. She was taken back up to theatre. She's an older patient. She's not going to survive an open repair. And so this is what we did. This is how you do a thoracic endovascular aneurysm repair. Basically, you do an angiogram once you've got the sheath. So you size you size the stent graft on the CT, and you do an angiogram with the stent graft ready to deploy. You can see the head and neck vessels here, and surprisingly, it's actually okay if you want to get your seal. So you need about 2 centimeters of seal for these, and you can actually get away with covering the left subclavian artery, and then the surgeons can do carotid subclavian bypass to keep the arm perfused if it's needed. So this is the stent deployed. We've landed it right on the left common carotid, which is still patent, and you can see we've covered the left subclavian there. So we've covered the rupture site, basically. And then this is her follow-up CT. So you can see, again, the aneurysm's not filling, it's just filling through the stent graft. And this is just a 3D reconstruction, basically, of how it sits, which is pretty cool. And these are great. And basically, electively, you would think maybe we'd use a different threshold for thoracic aneurysms, but the guidelines say 5.5 centimeters, so it's easy to remember that number. And again, if you have a ruptured thoracic aneurysm, consider, endovascular if you can. These are a lot more difficult, obviously, if they involve the ascending aorta, because the patient needs open surgery in that, because they obviously need their head and neck vessels, all of them being perfused. You can get away with covering the left subclavian, but not the others, really. And that's aortic and thoracic aneurysms. I'm just going to do a couple of minutes on pseudoaneurysms, because I think this is a really common misconception that that they're shouldn't be worried about as much. And actually, there's just a technicality in the difference to aneurysms. You see, this is from Radiopedia, and it just looks like pseudoaneurysms, just a different type of aneurysm, really. But that's not the case, and I think pseudoaneurysms really should have a lot more urgency around them when they're managed. Less so for like femoral pseudoaneurysms, because normally they're a bit safer and a bit less likely to rupture. Pseudoaneurysms elsewhere, particularly visceral abdominal pseudoaneurysms, should be seen as a contained rupture, and they should be seen as an urgent situation. I'll just very quickly go through a case. This is a 39-year-old guy, so a young guy, previously fit and well. He collapsed at home, had abdominal pain, was hypertensive, and it's really just not one of those causes of hypovolemia that you think about. So I remember this morning very well, because actually it was one of the first my first weeks as a consultant intervention radiologist, just under a year ago. And I was coming into work, I thought I had a pretty relaxed morning list. And instead what I found in the department was this slightly panicked looking anaesthetist, which, it's quite rare to see a worried looking anaesthetist. And so that made me very worried. And he said, look, this young guy's just had this CT scan. He's really not well. I'm not sure if he's going to make it back up to the unit. Can you have a look and see if there's anything to treat? And basically, he'd had this initial scan, in the night. And it shows, if you can see, all down the right side of his abdomen, he's got this really big hematoma. And I'm probably not going to be able to stop it on the right slide, but he's got a tiny pseudoaneurysm. Let me see if I can. I mean, it's very difficult to pick up, but he's got a tiny pseudoaneurysm, which has caused all this bleeding. And basically, he's got a hole in the side of one of his vessels. And the pseudoaneurysm, like I said, represents a contained rupture. So this was the second scan he'd had. Nothing had been done about the first one during the night. And now you can see that hematoma is even bigger. And he's got what is essentially active bleeding out of that hole in his blood vessel. And as you can imagine, if they tried to operate on this, they'd open the abdomen, they'd find a massive hematoma, they'd move it out of the way, and it would all start bleeding again. And the chances of them finding the bleeding point before the patient bled to death are very low. And this is one of the areas this is one of my favourite cases. I love being involved in interventional radiology for this. So he came straight to IR, and we did an emergency embolization. So you brief the team, you say, look, we're going to have to be quick. This is the equipment I need, and the patient's coming straight round. So I'll quickly show you the images, if it'll load, from the procedure. Basically, I've hooked a reverse curve catheter into his superior mesenteric artery and done an angiogram. I found the vessel, and you can see this bit here, this irregular vessel here. This is the pseudoaneurysm that's bleeding. Watch now. So there, you can see that bit of the vessel. So this is where you need your fine motor microcatheter skills. And I got it right up to the aneurysm, but I just couldn't get it across it. And the problem is if I just block the vessel before it, what will happen is the vessel the other side of it. So if we block just down here, the vessel will just start back bleeding and he'll continue to bleed. So this is a really important concept of back door, front door. So you need to embolize the other side of the aneurysm sac before you treat this side as well. So if you can't get your microcatheter across it, you need something called, I use glue basically, and you just inject the glue and you hope it doesn't go everywhere and you hope it occludes the vessel. And so what you can see here is I'm injecting after I've injected glue, and just over here, that's all glue in the pseudoaneurysm. And this guy had a long ICU stay, but eventually he went home and he's fine. So it's a really nice thing to be involved in, and these are some of my favourite cases, basically, pseudoaneurysm. So, in summary, aneurysms are really important. They're a very rewarding part of being an intervention radiologist, and I would definitely consider treating aneurysms as part of your practice. Remember, 5.5 centimetres is the threshold for elective repair, which is by no means perfect, as we talked about. And hopefully one of you will go on to invent some amazing artificial intelligence algorithm that will help us to treat only the patients that need treating. We do use an algorithm for risk prediction, which I think is really cool, but it's mostly the anaesthetists that do that. But it's really helpful, and it's a great example of technology helping modern medicine. There's still controversy, EVAR versus open. Hopefully I put you in the picture a little bit about it. It's difficult to know what to say about it, to be honest. The one thing I just wanted to mention, that if I wasn't clear about it, if you've got a ruptured aortic aneurysm and the patient is older, you always do an EVAR if possible over open repair. And finally, one of my bugbears is visceral pseudoaneurysms. They are a contained rupture. They're not a benign entity, and they need urgent treatment. Thanks for listening. Chris, any questions?
Thank you. Yeah, that was really fantastic talk. Really interesting cases, actually. So thank you for sharing those, and the presentation itself was really slick, and those the CT slides as well were fantastic. So thank you for the effort you've put in to put that together. We've got a question on risk prediction, actually, for elective. So we asks about NICE guidance, recommending only CPET and not other risk calculators such as the Carlisle calculator and other tools. I wonder if you can tell us, why.
So what I'd say about that is NICE. One of the benefits of NICE is they only recommend something if there's really strong evidence for it, and they have a very high threshold. So although John Carlisle has done a lot of work on it and published a lot of papers, and it does involve a lot of patients. I mean, they've evaluated it. They've evaluated a lot of risk predictors, and you can see that that how they've assessed it, and they're quite ruthless and brutal in their assessment of whether something's good enough. And although so even if you mention by nice, I think you've done pretty well. So I think they just tend to sit on the fence a bit more until there is almost overwhelming evidence for something, because they know the impact that's going to have.
Okay, so in reality, these calculators and risk algorithms are used as well as sort of nice guidelines.
Exactly. So although nice, they definitely have to use it. They kind of leave it open. I would, most places I've worked use it, and I think they just don't want to, make people have to use it. If you see what I mean, when the strength of the evidence isn't there completely, basically.
Okay, we've got one other question, unless anyone else has any more that they want to drop in the chat. So, if there's a pseudo aneurysm post cardiac angiogram, do you treat them, and what can you use for treatment? And does fibrin injection help?
Maricel, if there's a pseudo aneurysm post cardiac angiogram due to wrist access, do we treat them? What treatment can you use? I mean, I have to say, I've pretty limited experience with the radial ones. I think because the compression bands work so effectively, we really don't see them as often as femoral ones. And with something that's so superficial, what we would probably do, because we do see it with brachial excess sometimes, is we would get a CT or a really good ultrasound, and you assess the aneurysm neck. And if it's a really narrow neck, and and the aneurysm has been there just for a short period of time, I mean, we're talking days. If it gets past 7 days, normally it forms kind of like a pseudo capsule, and even injecting fibrin isn't going to help. And obviously, what you've got to realize is that area is so easily accessible surgically. You just cut down onto it. So we don't routinely treat those, actually. I think surgery often is a really good option for those kind of.
Got one further question just regarding screening. I think you can see it. So about ultrasound and CT being different, but
okay,
as I understand, the same.
Yeah. So good. I mean, this is a really good point from Hannah. There's something about CT and ultrasound. So basically, all the guidelines are based on ultrasound measurement to inner of the aneurysm wall. And but of course, what do we do a lot of the time is, the patient has the ultrasound, is referred for treatment, and then we measure it on CT and we measure it outer to outer. That's what everybody does. I mean, what I'd say is like we looked at that graph and we saw that. So basically, the answer to your question, Hannah, is it's on ultrasound, and it's supposed to be inner to inner aneurysm measurement is what the guidelines are based on. But in reality, we looked at that graph and we said, look, it's really just going on size is not perfect. It's a really, it's a helpful approach because it's very simple for us to use. But in reality, it's not the best. It's certainly not the best way. So I would say don't get too worried or caught up at those aspects of it, because it's really, you're splitting hairs on an imperfect method of sorting aneurysms, basically. So yeah, it's ultrasound and it's inner to inner, but size isn't great.
Cool. All right, I think that's all the questions now. So just want to say a massive thank you, Drew, for giving up your time. And yeah, it was a really fantastic talk. So I hope everyone watching has gained something from it, and hopefully many more people will by watching it on catch up. So thank you.
Lovely. Thanks, Chris.